Welcome to The Explainer. Today, we're jumping into a real classic, a neurology puzzle that is super high yield for your exams and your rotations. I'm talking about Brown-Séquard Syndrome. Okay, so let's just get right to the heart of it. This is the central mystery, the paradox of Brown-Séquard Syndrome. It doesn't seem to make any sense, right? How can that be? Well, stick with me because by the time we're done here, you are going to nail this diagnosis every single time. So here's our game plan. We're going to tackle that paradox, decode the spinal tracts, get into the classic clinical picture, see how to rule out other stuff, and then cover diagnosis, management, and of course, the big takeaways. All right, first things first. To solve this puzzle, we've got to understand the key players involved. Think of them as the main characters in our story, these three major spinal cord tracts. Okay, now this table right here, this is where the magic happens. Look at that third column, decussation. That's just a fancy word for where the nerve fibers cross to the other side. You've got the corticospinal tract for motor control and the dorsal columns for vibration and proprioception. You know, your sense of where your limbs are in space. Notice they both cross way, way up in the brainstem. But then there's the spinothalamic tract. This guy is the exception. He's carrying pain and temperature info, and he crosses over almost right away, right there in the spinal cord. And believe me, that one little detail, it changes everything. Okay, so now that we know our key players, let's get to the scene of the crime, so to speak. We're talking about a one-sided injury, a hemisection of the spinal cord. And you're about to see how that anatomy we just discussed perfectly explains the bizarre symptoms that pop up. Right, so what exactly is Brown-Séquard syndrome? The key word here is hemisection. Hemi means half. We're not talking about the entire cord being severed. The injury only affects one half of the cord, either the right or the left side at one particular spot. And look, this isn't just some weird thing you only see on exams. This happens for real. The classic example everyone learns is a penetrating injury, like a stab wound. But it can be caused by all sorts of things. A tumor pushing on one side of the cord, an MS lesion, a big disc herniation, even an abscess or a bleed. Okay, here it is. This is the big reveal, the moment it all clicks into place. So let's say the injury is on the right side of the spinal cord. It hits the corticospinal and dorsal column tracts on that right side before they've crossed over. So what happens? You get weakness and loss of vibration on the same side as the injury. Ipsilateral. Makes sense, right? But remember our little friend, the spinothalamic tract? The fibers for pain and temp from the left side of the body have already crossed over to the right side by the time they get to the lesion. So that right-sided injury knocks them out, causing loss of pain and temperature on the opposite side, the left side, contralateral. And that right there is the signature, the classic triad of Brown-Séquard. Now, to really become a localization pro, there's one more layer here. You have to think about what's happening right at the level of the injury versus everything below it. See, right where the damage is, you're knocking out the nerve roots as they're exiting. That gives you lower motor neuron or LMN signs, like flaccid paralysis. But for everything below that level, you've cut off the signals coming down from the brain. You've damaged the upper motor neuron pathway. So that gives you UMN signs, like spasticity and a positive Babinski. All right, so let's get practical. In the ER or on your boards, it's not enough to just recognize Brown-Séquard. You've got to be able to tell it apart from the other spinal cord syndromes. Let's talk about its unique signature. And really, this is what makes it stand out. It's those crossed findings we talked about. Ipsilateral motor and vibration loss with contralateral pain and temperature loss. That is the dead giveaway. No other major cord syndrome does this. Think about it. Anterior cord syndrome, it takes out motor and pain on both sides but saves vibration. Central cord, that's the one with weakness that's way worse in the arms than the legs. So when you see that specific crossed pattern, you should be thinking Brown-Séquard. It's a clinical signature. Okay, great. So your exam is screaming Brown-Séquard. What now? How do you lock in the diagnosis and figure out what's causing it? Let's go through the steps. It all starts with you, right there at the bedside. Your focused neuro exam is step one. You've got to be super thorough. Test motor, test reflexes, and check all the sensory modalities. Pinprick, temperature, vibration, position sense, you name it. And you've got to do it on both sides, carefully mapping out where the sensation changes. That's how you're going to pinpoint the level of the lesion. And then, after your exam, you need to see what's going on. And for that, you need imaging. Now, a CT is great, don't get me wrong, especially for looking at bones and fractures, but it won't give you a good look at the spinal cord itself.
That's where MRI comes in. MRI is the undisputed king here. It's the gold standard. It'll show you the core damage directly, and it'll show you why it's damaged. Is it a hematoma, a tumor, an abscess? MRI will tell you. So you've got the diagnosis confirmed on MRI. What do you do next? Well, management is really a two-pronged attack. First, you stabilize the patient so things don't get worse, and second, you go after the underlying cause.
Look, this is a true neurologic emergency, so first things first, ABCs. Airway, breathing, circulation. That's always number one. If there's any chance of trauma, you're going to immobilize that spine immediately. After that, your treatment really depends on the cause. If there's something compressing the cord, like a bleed or an abscess, that patient might need to go to the OR right away. If it's something inflammatory, like MS, that's going to be a medical treatment. And then, of course, rehabilitation is absolutely critical for the long term. It's funny, we spend so much time learning about this, and it's a total classic, but it's important to keep in perspective that it's actually pretty rare. We're talking only about 1 to 4% of all traumatic spinal cord injuries. So, a classic, yes, but not something you see every day.
Okay, let's wrap this up with a few super high-yield pearls, the stuff you absolutely need to know for your exams. First, if you see Brown-Séquard signs, plus a droopy eyelid and a small pupil on the same side, you need to be thinking Horner syndrome. That tells you the lesion is high up, above T1. Second, a tricky localization point. The pain and temp loss actually starts a level or two below the injury. Third, the good news. Of all the incomplete spinal cord injuries, this one often has the best prognosis. And finally, if you need a quick way to remember which tract crosses, just remember that the spinothalamic tract is a traitor. It betrays its own side and crosses over right away.
All right, time for a quick pop quiz. A classic case. You've got a 25-year-old guy who got stabbed in the right side of his neck. His exam shows he can't move his right leg and has no vibration sense there. But he can't feel pain or temperature in his left leg. So what have you got? And if you said Brown-Séquard syndrome, you nailed it. Absolutely correct. See? You took the pieces, you understood the pathways, and you put it all together to solve the puzzle. That's what localization is all about. So that really brings us to the big picture here. Becoming great at neurology isn't about memorizing a huge list of syndromes. It's about truly understanding the pathways. The single most important thing you can take away from this is that if you know where the major tracts run, and more importantly, where they cross, you can solve almost any spinal cord localization problem. So what pathway are you going to master next?